Hello, welcome to the first in a series of short videos demonstrating the key components of the gastroschiesis care protocol used in the gastroschiesis interventional study in Ghana, Zambia, Malawi and Tanzania. In reality, the care protocol is tailored to each individual setting. I shall cover the core components in these videos. This first video is how to get the baby from birth to the tertiary paediatric surgery centre in the best possible condition. All aspects of care are aimed at trying to prevent the three leading causes of death. These are sepsis, dehydration and hypothermia, and to protect the bowel as much as possible. And you may have a protocol similar to this to follow at your centre. So firstly, when the baby is born, place it onto the mother's abdomen as normal and dry the baby all over to prevent hypothermia. During this time you can reassure the mother. You can say something like, don't worry, you've seen this condition before, you know how to manage it and care is available. You can practice delayed cord clamping. So clamp the cord 1 to 3 minutes after delivery. This will help to optimise the blood volume in the baby and perfusion to the bowel. You can then cut the cord at 8 to 10 centimetres. You don't need to measure it, you can just estimate. But this long cord will help us to close the defect, the hole in the abdominal wall, at a later date. Then transfer the baby to a dry towel, preferably on a radiant heater to keep warm. Cover the head to prevent heat loss, either with a hat, towel or sheet. You want to prevent heat and fluid loss from the intestines as well. So cover the bowel in clean plastic. So a clean plastic bag such as this, any other clean plastic bag. You can use cling film, you can use clean plastic apron, anything you have available. Obviously you'll resuscitate the baby as required and provide oxygen if needed. Of note, it's important not to apply wet gauze to the bowel. That can dry onto the bowel during transfer, causing bowel damage, and wetting that gauze can cause hypothermia in the baby. So now you want to proceed to cannulate the baby. Of course it takes slightly longer in real life. You want to give a 20 ml per kilogram normal saline fluid bolus. So despite your measures there will be some fluid loss from the bowel and you want to prevent dehydration. You want to also give some broad spectrum antibiotics such as penicillin, metronidazole and gentamicin. This is to prevent sepsis. And you can then start 10% dextrose maintenance fluids at the normal rate for a baby on the first day of life. You can also give vitamin K as you would to any other baby. You're then in a position to insert a nasogastric tube. So measure this as normal and then add an extra 3 to 5 centimetres so that it can reach down to the stomach, which is often protruding outside the abdomen, as you can see here. You want to see that stomach deflate as the nasogastric tube enters the stomach. And you can then leave that on free drainage until the baby is at the tertiary paediatric surgery centre. Putting the end into a glove is fine. And use some strong adhesive tape to ensure that stays in position during the transfer. Now really important is to keep the baby warm throughout their time with you and during the transfer. If you have a radiant heater, keep them on that while they're with you. If not, the baby can be placed in skin to skin kangaroo mother care, but in a modified position, in a breastfeeding position instead, with the bowel on top of the baby's abdomen. Make sure there's no bowel dangling over the side as that can damage the bowel. But you don't want the baby outside the clothes, you want the baby inside the clothes like this so that they're skin to skin. Obviously the bowel is covered with plastic at this stage. The mother can give a 5-minute breastfeed as well. Then aim to transfer to the tertiary centre as fast as you can. Aim to leave your centre within an hour of birth or an hour of arrival if they've been referred to you. Every hour sooner that the baby gets to the tertiary centre is a higher chance of survival. During transfer, keep the baby skin to skin to keep them warm, and give a good referral to the tertiary centre detailing when you gave the antibiotics and what care you provided so that they can continue the care seamlessly when the baby arrives their end. This is the second in our series of short videos demonstrating the key components of the care protocol used in the Gastroschiesis interventional study. This video is focused on the resuscitation of the neonate on arrival to the tertiary paediatric surgery centre. Many of you will have a gastroschiesis protocol similar to this, which you can follow for guidance. So upon arrival, place the baby on the radiant heater or resuscitator. You can ask a colleague to kindly call the paediatric surgical team to alert them of the arrival of a baby with gastroschiesis. Then we're going to follow an A, B, C, D, E approach to resuscitation. So A for airway. Is the airway patent? Is the baby crying? Do they need an intervention to help open the airway? B, breathing. I'm going to put on a saturation monitor. I'm going to look at the breathing. I happen to notice that the bowel is not covered with plastic as we would like it, so as the saturation monitor is picking up, I'm going to very quickly slip on a plastic covering to prevent any further hypothermia and fluid loss during the resuscitation time. Still not picked up, so I'm just going to quickly dry the baby, discard this towel, get a dry towel and put a hat on. Okay, so the saturation's now picked up. In a term baby, I'd like to see the saturation above 94%. In a preterm baby, it can be between 88 to 92%. If it's lower than this, I'll apply oxygen to get it within that range. Then I'll move on to C for circulation. I want to check the heart rate of the baby. Should be between 110 and 160. If it's above 160, it may signify that the baby is either dehydrated or septic. I'm going to check the central capillary refill, so I'm going to press on the sternum for 5 seconds. 1, 2, 3, 4, 5. I'm going to release. Normally the colour would come back within 2 seconds. If it takes longer than that, it may signify that the baby has shock. I want to check that the baby has a functioning cannula. This baby thankfully already has a cannula from the district hospital. I am flushing it and this does thankfully work. If not, I would have placed a peripheral cannula. This can be very challenging if the baby is septic, dehydrated or hypothermic, in which case you can use the umbilical cord for umbilical vein catheterization. I'll also check the referral for the baby. How old is the baby? Have they been given any fluid in the local hospital? In most cases, the baby will require a 20 ml per kilogram fluid bolus. So if this baby is 2.5 kilograms, I'm going to give 50 ml of normal saline. At the same time, I can look up whether the baby has had antibiotics, and if they haven't, I'll give broad spectrum antibiotics as well, something like penicillin, metronidazole and gentamicin, or equivalent according to the local policy. At this stage I could also send off bloods, full blood count, Usanese and a blood culture. And I can set up some 10% dextrose maintenance fluids. A, B, C, D. Okay, I want to check the conscious level of the baby and also the blood glucose level. If the glucose level is low, I can also give a bolus of 10% dextrose. E for exposure. I'm going to check the temperature of the baby to know how much the baby needs to be warmed up under the radiant heater. I'm going to just have a quick look all around the baby to see if there's any other obvious pathologies. Okay, so I've done A, B, C, D, E. Now I can check the nasogastric tube. Is it in position? I want to aspirate on that. I'm going to aspirate as much as I can out. So I've managed to aspirate 50 mils. This is what an inflated stomach looks like in gastroschiesis. You want to see that that balloon-shaped stomach has flattened with decompressing and aspirating on the nasogastric tube. Whatever volume of bile is aspirated, you want to then replace mil for mil with normal saline intravenously to prevent dehydration. And that nasogastric tube can remain on free drainage. Okay, at this point we're ready to apply the preformed silo, and we're going to speak to the surgical team regarding whether they can be here within an hour to do that, or whether the team on the neonatal unit or on the paediatric surgical ward are going to apply the silo. Hello, this is the third in our series. This video is focused on application of the preformed silo, and you may have a protocol similar to this at your centre to follow. So you want to make sure that the baby is on the radiant heater or resuscitaire. You want to gather the appropriate team, so someone to help support and comfort the baby throughout the procedure, either with 10% dextrose on a finger to suck or on some gauze as shown here, and ideally another assistant to help the person applying the silo. You want to do a full A, B, C, D, E check to make sure the baby has been fully resuscitated and their condition optimised beforehand. Make sure they've had their antibiotics, some paracetamol, and again aspirate on the nasogastric tube to make sure the stomach is fully decompressed before you begin. Then you want to ask your assistant to kindly remove the plastic. Do this at the last minute so that the bowel is exposed for the least amount of time. Then, wearing sterile gloves, you want to check the bowel from one end to the other on both sides to check whether this is simple gastroschiesis with normal bowel, for which you can use a preformed silo. This is the majority of cases. Or whether this is complex gastroschiesis with a perforation, so a hole in the bowel. Or whether there's necrosis, a black section, or whether there's atresia with two blind ends or a wide dilated section going into a much thinner section. For complex gastroschiesis, there needs to be an individualised surgical plan, and if you're not going to immediately apply the preformed silo, reapply the plastic so that the bowel is not exposed for any longer than necessary. So this is simple gastroschiesis. We're going to proceed to silo application. First of all, I'm going to do a finger sweep using my little finger to check whether there's any adhesions between the abdominal wall and the bowel. If there are, then the surgeon can divide these normally at the cot side. Okay, so this is free. I'm going to apply an Alexist silo, and most times I use the green ring. I'm going to imagine the baby as a clock face. 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. I want the cord here to remain at 6 o'clock throughout the silo application, and the seam here at the top to remain at 12 o'clock without any twisting, as that can twist the bowel inside, which can cut off the blood supply, resulting in bowel necrosis. I also want to feed in the apex of the bowel first. So you can see on this baby with matted bowel that the apex is the top part of the bowel, which goes into the silo first. So I'm then going to gently feed in the bowel into the silo, ensuring there's no twisting. If at any stage I see that the silo is twisted, either during the procedure or at the end, I'll remove the silo completely and start again, because simply twisting it back could mean that the bowel is twisted inside, which can result in bowel necrosis. So once all of the bowel is inside, I'll then pinch the green ring thin laterally, so it's the same size as the defect. I'm then going to push the inferior end in down towards the bladder. I'm going to swap hands to keep the green ring pinched thin. I'm then going to push it in a cranial caudal position down towards the bladder so that the ring pops into the abdomen. And sometimes it can be a little bit tricky. I choose this direction because I don't want to be pushing up onto the liver. Once it's in, again check that that string is at 6 o'clock. If not, remove the silo, make sure the bowel's not twisted, and start again. Now the bowel is in, you can apply warm saline, wash the bowel, tip that out, and you can repeat that to ensure the bowel has been fully washed. Then we're going to tie the silo from above. You don't need to tie it down tight at this stage. We'll let the bowel settle before doing any reductions. So we'll tie it up tight. Make sure it's directly above the patient, not tilted to one side or the other, and the baby must be lying on their back. This is because if it's tilted, the blood supply can be compromised and the bowel necrosis occur. So once you're in that position, you can apply some wet gauze, saline soaked gauze, to the cord. Make sure that it's covered all the way to the base, because you want to use that for the closure. Before applying that, I would clean the abdominal wall and cord thoroughly with an antiseptic solution to make sure it's as clean as possible. At this stage, you can do a full ABCDE check, ensure the clinical condition is optimised again, and make a clear plan, both written in the notes for the team, but also a verbal handover to the team that are going to be caring for the baby, to make sure the bowel will be monitored closely, the condition monitored, and there's a plan for the patient's care. Hello, this is the fourth in our series. This video is focused on tips and tricks for preform silo use. Firstly, which silo to use. We are using this Alexis wound protector and retractor, extra small, 2 to 4 centimetres, produced by Applied Medical. This is about 1/10 of the cost of the purpose-made preform silos used in high-income countries. There are also videos available for making preform silos using local resources. Those are preferable than using a female condom, because a female condom, the ring is often too flexible and can pop out, and this component is very weak and often splits and allows the bowel to spill out. So use either a purpose-made or a makeshift preform silo preferably. So next, what to do if you're faced with a particularly small neonate. We found that neonates that are 1.5 kilograms or less, the green ring of the Alexis silo fills the perimeter of the abdominal wall, and you can actually use the other end, this white end, cut off the external ring. Make sure you use a sterile blade or scissors so that it's still sterile to insert into the abdomen, and also make sure it's still smooth so there's no rough edges to damage the bowel. But you'll find this has a smaller diameter and is more flexible for the smaller babies. So what to do if you have a particularly small defect or hole in the abdominal wall that's 2 centimetres or less? You can still use this Alexis silo, insert the green ring and tie up the silo from above quite tight for the first 48 hours without doing any bowel reductions, and you'll find the defect stretches up and comes to a more normal size for you to be able to proceed as you normally would. However, make sure you diligently watch the bowel colour, because when inserting an Alexis silo through a small defect, you have to manipulate it and twist it to get it to go in, and that increases the risk of twisting the bowel during silo application. So monitor the bowel regularly. If there's any discoloration of the bowel, remove the silo, check the bowel's not twisted, and then try reapplying it. If you find the bowel still becomes discoloured, you can make an incision to enlarge the size of the defect slightly. We only do this when necessary because what we've found, if you've put an incision, the defect can stretch up more quickly while the silo is on, making it slightly higher risk for the ring to pop out towards the end of your period, reducing the bowel. So tips for keeping the cord moist. What we started using and what many centres still use is the wet gauze covering the cord, wet regularly with saline by the nurses day and night, and also checking that the cord is completely covered to the base, because if it slips up, the base of the cord can dry out. If you're having problems keeping the cord moist, there's an alternative, which is tucking the cord in to the abdominal wall at the time of silo application, and you can see that the cord is then inside. Make sure it's fully in, and at the time of closure you can do a finger sweep and pull that back out, ready to use. So what about tips for avoiding the silo popping off? Firstly, make sure the baby remains on their back at all times. You can have a folded sheet or towel around the baby to keep them in position. If you're doing a procedure like cannulation, make sure you loosen the silo, because manipulating the baby with this tied up can actually pull the ring out. Also, once you have reduced the bowel by about half or more, you don't have to have the silo tied so tightly from above. So relax it slightly so the bowel is still upright, but not tied so tight, and you'll find that then the defect doesn't stretch up so quickly. Also, make sure you try and reduce the bowel, ideally within 5 to 7 days, to reduce the risk of that ring popping out. Finally, what about minimising risk of infection? So the Alexis Silo has this black string at the bottom. It has a pendant at the end normally that you can flip over the top or tie it up as I've shown here, and that prevents it from dangling in the nappy, which is a direct route for bacteria to enter the abdomen. Also, make sure that you keep the abdominal wall and the cord as clean as possible. Regularly clean it to minimise the amount of bacteria that can enter the abdomen through the hole in the abdominal wall. Hello, this is the 5th in our series. This video is focused on the daily ward care of the neonate with gastroschiesis. Ideally, the baby should be assessed at least every 4 hours if they are stable with vital signs that are within normal range. If the baby is unstable with abnormal vital signs, they should be reviewed ideally every hour at least, with an action taken to try and correct those vital signs each time. So what are we going to do during an assessment? First of all, a full set of vital signs. I'm going to check the oxygen saturation. I want to ensure that for a term baby it's above 94%, and for a preterm baby it's between 88 and 92% or higher naturally. If not, we will give oxygen as required. I'm going to check the central capillary refill time as discussed before, and the baby's heart rate. If this is prolonged or the heart rate's above 160, I will consider giving a 10 ml per kilogram normal saline fluid bolus, because babies with gastroschiesis often lose additional fluid from around the base of the silo, and there may be other reasons why they're fluid depleted, such as having a cannula tissued and going a few hours without maintenance fluids. Okay, I also want to check the baby's core temperature and correct that if it's abnormal. Then on to the nasogastric tube. I'm going to aspirate that as much as possible because I want the volume of fluid in the bowel to be reduced so we can get that bowel back into the abdomen. However much fluid is in the glove that's been draining plus that I've aspirated, I'm going to add those together and replace them mil for mil with normal saline or Ringer's lactate intravenously. I will also make sure at this stage that the baby's received their antibiotics and any other medication as prescribed. Now onto the bowel. I want to check that the bowel is pink. If it's discoloured in any way, I will act immediately, knowing that if I don't, the bowel can become necrotic. And there is another video detailing of how to manage that situation. I'm going to check the string of the silo is up and not dangling in the nappy. I'm going to check that the silo is suspended upright and not tilted one way or the other. I'm going to check that the gauze around the base of the silo is clean and if necessary replace that. The same for the gauze around the cord and make sure that that's wet and all the way to the base so that the cord's not drying up. If I need to change these, I'll also take the opportunity to use an antiseptic solution to clean the abdominal wall and cord to keep that decontaminated as much as possible. I'm then going to move on to feeding. I'm going to give the baby 1 ml of express breast milk every 8 hours. And if the baby becomes upset or distressed in between, they can have a breast milk lollipop, either on gauze or on a finger, to help soothe the baby. And the mother can help with those. And indeed, the mother should be supported throughout this time and encouraged to express breast milk every 2 to 3 hours day and night to ensure that she has a good milk supply when the baby comes to breastfeeding in a few days' time. Finally, we want to ensure that the baby has some parental nutrition support if it's available locally. So this can include simple amino acids, something along the lines of astamine or indeed celamine, and the celamine can be given with or without Celipid if Celipid is also available. Or you may go for something slightly more comprehensive such as Cabiven, which is being used in Tanzania. Hello, this is the 6th in our series. This video is focused on reducing the bowel, also called silo tucks. First of all, you need to prepare for this procedure. You want to do a full set of vital signs and correct any that are abnormal. You want to fully aspirate on the nasogastric tube to reduce the volume of fluid in the stomach. And you can also do, if you wish, a normal saline enema aimed at reducing the volume of stool in the bowel. So you can use a soft tube with some lubricant and 20 mils per kilogram of warmed normal saline. And you're going to infiltrate that in gently as you're inserting the tube. And then you can gradually withdraw and aspirate. That'll help loosen up some of that sticky meconium and reduce the volume in the bowel. You also want to soothe the baby during the procedure, so with 10% dextrose or ideally some express breast milk on a finger or some gauze during the procedure. Now we're ready to do the silo tuck. Now you want to put your hands around, it's not a pushing from above, it's your hands around as if you're reducing like a hernia. So I'm going to push that down as much as I can, that's comfortable, and then I need a second person to tie underneath. This isn't a single person job because if I was to let go to do the tying, then the bowel would come back up again and I wouldn't get such a good reduction. So it's a 2-people job. And you can see we're aiming to reduce the bowel by 1 or 2 centimetres each time. You want to make sure that doesn't slip up, and you can give it a quick pinch to make sure there's no bowel caught underneath. Okay, so then let's pretend it's in the afternoon. We're aiming to do a silo tuck twice a day and get all of the bowel back in within 5 to 7 days. The only exception to this is if you've got a baby who has an oxygen requirement or is septic, then you may need to go a little bit slower. Okay, so we've got our next tuck there, and we're going to keep on reducing that down as much as we can. And each time I'm going to do that full assessment beforehand, and also I will check a full set of vital signs after doing a tuck, particularly the oxygen saturation, to check that there hasn't been any compromise by putting added pressure onto the diaphragm. So you can see that we're getting that bowel back in now. It's important that it's a gradual process over a few days, so that abdominal wall has got time to stretch up and the bowel volume is reducing down, and we're starting to get down there now. Brilliant, as tight as you can. It doesn't slip back up. We want to get the bowel completely flat within the abdomen. There shouldn't be any mushrooming out at all. So we're nearly there now. We're getting there. You can even give the silo a little bit of a twist when you get towards the bottom to help keep it down. Another point to note is once you tie the silo, the excess string or gauze that's dangling should be cut off, otherwise it just dangles down and there's an infection risk. Also, you should loosen the tie from above slightly, particularly when you get into these lower reductions, otherwise it can pull out. And you can see now we're on day 5 to 7 and the bowel has been fully reduced into the abdomen. This is the 7th in our series of short videos. This video is focused on removal of the preformed silo and closure of the defect. You need to prepare for the procedure, get the baby on the radiant heater, gather your team, someone to do the procedure, someone to assist, and someone to soothe the baby throughout the procedure, either with dextrose or breast milk on a finger to suck or on gauze. You want to do a full ABCDE assessment and correct any vital signs that are abnormal. Fully aspirate on the nasogastric tube to decompress the stomach. You can also do another saline enema to decompress from below. You want to make sure that the bowel itself has been fully reduced and flat within the abdomen without any little mound for 24 hours prior to the procedure to optimise your chances of closure and reduce the risk of reherniation afterwards. Before doing the procedure, you want to fully clean the abdominal wall and cord with an antiseptic solution and dry it thoroughly so that the dressing can stick. Then get your sterile gloves on. You're going to wrap this string around the fingers of your left hand, whether you're left or right-handed, and then as you see the green ring coming up, you're going to push your fingers underneath to make sure that the bowel does not come out. And this is very important because if the bowel comes out again and you have to reapply the silo, it's a very high chance of mortality in the lower resource setting. So I've got the bowel in there. Again, I will dry. I'm going to pull the cord across. Now, if the baby is septic or requiring oxygen or premature, I will just lay the cord gently across the defect so that I don't increase the intra-abdominal pressure at all, which can cause decompensation. But if the baby is well, I can pull the cord across and oppose the two edges of the defect, but I want to keep my fingers there the whole time to make sure that the bowel doesn't come back out again. I'm going to place steri strips, or if you haven't got steri strips, you can use clean new roll of strong adhesive tape. I'm going to place them on the top and the bottom like that. Then you get 12 by 10 centimeter Tegaderm dressing. I've cut it using sterile scissors to the center. I'll place one in one direction, flip up the cord and place another in the other direction. Obviously in real life I would remove the back so that it sticks down, and that dressing would stay for 10 days. The cord would dry up and it would heal. Now if you have not opposed the two edges of the defect, then you want to keep the cord underneath the dressing so that it can help keep the bowel inside and act as a natural dressing in that area. So I'm then going to apply strips from top to bottom as well over the cord, so the cord is keeping the bowel inside. The whole time I'm keeping my fingers centrally to prevent any bowel reherniation. I'm then going to get a square of sterile gauze and put that centrally, which will help soak up any fluid that leaks from the abdomen and also helps provide a little bit of pressure in that area to prevent bowel reherniation. I'm going to get a 10 by 12 centimeter Tegaderm dressing and apply that across the whole abdomen, making sure it is stuck down very well. If at any stage it's not sticking, you dry again and you might need to use a new dressing, or you can reinforce the edges using a smaller section of Tegaderm dressing. So sticking down, you may want to cut off these protruding edges of steri strip and or cover with another small Tegaderm at the edge there. Key is to keep this dressing in place for 10 days without removing it, even if it starts to look messy under the dressing, because if you remove it before 10 days you can get re-herniation of the bowel. Okay, so I would maybe need another one of those little dressings as well in this situation to keep the dressing completely covered all the way around. I'd need another little one. Hello, this is the 8th in our series. This video is focused on establishing breastfeeding, changing the dressing, discharging the patient and following them up. This baby had their abdomen closed today. I'm sorry that the dressing doesn't stick so well in these silicone models. Now we're going to use a breastfeeding protocol to establish the breastfeeding for this baby. The quicker we can get the baby breastfeeding, the higher the chance of survival. So the first day of closure, you don't make any changes. The baby can still have 1 ml of express breast milk every 8 hours and can be soothed in between with breast milk on gauze or on a finger. The nasogastric tube is still on free drainage and should be aspirated every 4 hours, and the losses replaced mil for mil intravenously. The next day, you're still leaving the nasogastric tube on free drainage, but the baby can start breastfeeding. That's 5 minutes of breastfeeding every 8 hours, and it can be timed by the nurses to help the mother and recorded in the notes. You no longer need to aspirate on the nasogastric tube. Then the following day you're going to clamp off the nasogastric tube and repeat with the same. 5 minutes of breastfeeding every 8 hours. And you'll gradually build up as the days go on following the protocol. So the next day will be 5 minutes 6 hours, And then the next day 10 minutes 6 hourly, and then 10 minutes 4 hourly, 15 minutes 4 hourly, and then 20 minutes every 2 to 3 hours, which is full breastfeeding. Now, how to monitor whether you can go up or not. It's okay for the baby to have small posits. That's a normal process. Even if they're slightly bile stained, that's quite common in babies with gastroschiesis. You don't need to stop going up the protocol as planned. Obviously, if the baby vomits profusely, then you'll need to stop and go back to what the baby was tolerating on the day before, and then start building up again. One thing we do that can help is to have the baby slightly inclined in their cot by placing something under their mattress. Once they're half breastfeeding, you can reduce the amount of parental nutrition support by half, and then obviously stop the parental nutrition when they're fully breastfeeding. And the baby should be gaining weight for at least 2 to 3 consecutive days before they can be discharged. Okay, so what about this dressing? Now, it's important to be vigilant to make sure that this dressing does not come off within the first 10 days. If you start to see it peeling off, you need to change it in the same manner that it was applied during the closure period, with the baby sucking on some milk to keep them settled. As you peel off the dressing, you should put your hands and hold the wound centrally to prevent bowel reherniation. Clean it, apply the strips and another tegaderm. If the bowel does reherniate, you can get this sort of appearance, and this herniated bowel can fistulate, which is associated with a high mortality. So you must try and prevent that at all costs. So once the dressing has been on for 10 days, however, you can then change it. Please don't change it routinely beforehand. It always starts to look discoloured underneath. You don't need to change it for that reason. So at 10 days, you can remove the dressing. This is what you'll see. The granulation tissue over the bowel, and the cord will still be moist because it's been under the dressing. The wound is not secure and strong at this stage, so you can't, during the dressing change, you want to keep your fingers on to support it, and you can't leave it without a dressing or it could reherniate. So apply a square of gauze and another tegaderm. Then, before the baby goes home, normally within the next few days, you want to change the dressing again. You can see that the defect has decreased in size, the granulation tissues become stronger, the cord is still moist. So apply another square of gauze and tegaderm, and at this stage the baby can go home, and then see them either in your clinic or in a district hospital under your surveillance in a week's time. And this is what the wound can look like then. It's got much stronger, the cord has dropped off, you can clean it up and apply honey, and after about 3 weeks following the closure, you no longer need to apply a dressing and it should heal up. This is just 3 days later. You want to, at that follow-up appointment, also make sure that the baby's opening their bowels regularly. If not, you can use a glycerine suppository as required, and make sure the baby continues to grow. And you'll want to see them weekly for the first few weeks to check the wound, check the baby's growing, and check their passing stool. And this is what the baby can look like at 3.5 months of age. You can hardly tell that they've had gastroschiesis. Some may have umbilical hernias, but they can be managed at a later date. Hello, this is the 9th and last in our series. This video is focusing on recognising and managing discoloured bowel within the silo to prevent bowel necrosis. Why is this important? Bowel necrosis within the silo is one of our greatest concerns and complications that we want to avoid. It can be avoided if recognised and managed early. So first of all, what does discoloured bowel look like? Well, normal bowel is pink and well perfused within the silo throughout. If you have any discoloration, that could be a brown colour such as this, it can be a purple colour, a grey colour, any colour that's not pink, suggests that the bowel is underperfused, and it can be a single loop, it can be just the top of the bowel or a region of the bowel, or it can be the entire bowel. So once you've recognised that, if you do something about it, it can become pink again and the baby can survive. If it's left for even a few hours, such as overnight, the bowel will continue to become necrotic, completely die, as shown in these images, and then it's very unlikely that the baby will be able to survive. This is irreversible. Whereas when you see the bowel discoloured like this, it's still reversible. So what can be causing this? Well, there's a number of things. Firstly, you want to check that the bowel in the silo is upright, positioned above the baby and tied directly above. If the bowel is flopped to one side or the other, it may be that the blood vessels into the silo are kinked and therefore the bowel becomes underperfused. The other thing that can happen is maybe the baby is sick. They may be underperfused, dehydrated, septic, and that could cause them to have a low blood pressure and low perfusion of the bowel. So make sure the bowel is strung up from above properly. Then do an A, B, C, D, E, full assessment of the baby and correct all of the abnormalities in the vital signs. They may need some oxygen, they may need a fluid bolus, 10 or 20 mils per kilogram, to help perfuse the bowel. If those are undertaken and the bowel is still discoloured, you must act immediately to prevent moving on to that gangrenous stage. It may be that the bowel was twisted on application of the silo, and that's one of the commonest causes of necrosis in the bowel, and you would see that within a few hours of silo application. That can be more commonly seen, as mentioned in a previous video, if the defect is particularly small and the ring had to be manipulated and twisted to get it in at the time of silo application. So one thing you can do if you're unsure if the bowel is discoloured is open the top of the silo, lift it down slightly and see whether the bowel looks pink or not. But normally the thing to say is, if you think the bowel is discoloured, it probably is. With the mother's permission, you can take a photograph of the bowel and send that to the surgical team if they're not immediately available. If they can't come within an hour, it's likely that they'll recommend for you to take off the silo. You just literally pull on the string and the ring will pop out. It's as simple as that. You don't need any training. You lift off the silo. Check that that bowel is not twisted. It may have been twisted in the silo, so lay it out properly. And then you can turn the baby onto their right hand side to help the blood flow into that bowel. Make sure that you replace plastic over the bowel to prevent bowel damage, fluid and heat loss from that bowel. And you can get a warmed saline pack, not hot but warm, to lie next to the bowel to help with the perfusion, and surgeons may even massage the mesentery of the bowel to help improve the perfusion. You can leave the baby like this until the bowel becomes pink again, and then hopefully by that time the surgeons will be able to arrive and you'll be able to ensure the baby's fully resuscitated, reapply the silo without any twisting of the bowel. Now, if when you reapply the silo the discoloration returns, it may be that the defect is too small and the surgical team need to make a small incision to enlarge the size of that defect. Now, one other thing is to have a poster on the wall that you can put up next to any baby with gastroschiesis, so the management of discoloured bowel is very clear to anyone, even if there's a new staff member. And really there needs to be a good handover, particularly with the night team, as that's the time when there's fewest people around and greatest risk of the bowel becoming discoloured without anyone noticing.